Today, we're going to discuss anesthesia procedures, methods, and techniques, a potpourri of anesthetic issues that you may face when undertaking the ABA examinations. We're going to review a number of subjects shown here on the slide and begin with pre-medication. Let's begin with a question, which is, which of the following most accurately arranges the anticholinergic drugs in descending order of anti-sialagogue effect? A, scopolamine greater than atropine greater than glycopyrrolate. B, glycopyrrolate greater than atropine greater than scopolamine. C, glycopyrrolate greater than scopolamine greater than atropine. And D, scopolamine greater than glycopyrrolate greater than atropine. And the correct answer is scopolamine greater than glycopyrrolate, which is greater than atropine. Anticholinergic agents are not as commonly used today as was in the past, but we do use them with specific indications. And we're going to talk about the potency of these agents with respect to their anti-sialagogue effect, most potent, least potent, which has the duration, least duration of action. So anticholinergic agents have been used to dry up the upper airway for many years. Scopolamine is the most potent drying agent, 3 times greater than atropine. It is less likely, however, to increase the heart rate and more likely to produce sedation and amnesia than the others. Glycopyrrolate is a more potent and longer-acting anti-sialagogue than atropine by quite a ways, but it is less likely to increase the heart rate than atropine because glycopyrrolate is a quaternary amine. It does not easily cross the blood-brain barrier and itself does not produce sedation. And you can see the summary of the 3 agents, atropine, glycopyrrolate, and scopolamine, in terms of their relative effects on heart rate, drying, and sedation. And so this table really summarizes everything we just talked about. Scopolamine and atropine may cause CNS toxicity because they cross the blood-brain barrier, the so-called central anticholinergic syndrome. Most likely it occurs after scopolamine, but if one gets into excessively high doses of atropine, and I'm referring to doses in excess of 100 mics per kilo, we may see these kinds of effects. The symptoms from the CNS toxicity of the anticholinergic agents include delirium, restlessness, confusion, and obtundation. Elderly patients and patients with pain may be particularly susceptible to these CNS toxicity. Excuse me. And these CNS toxic effects are potentiated by inhalational agents. The treatment is definitive, 1 to 2 milligrams of physostigmine. Mydriasis and cycloplegia from anticholinergics are unwanted in those with certain types of glaucoma because they increase intraocular pressure. It's unlikely, though, to occur with smaller doses. And atropine and glycopyrrolate are less likely to increase intraocular pressure compared with scopolamine. Because anticholinergic agents block vagal activity, a relaxation of the bronchial smooth muscle occurs and respiratory dead space increases. The magnitude? It depends on the existing bronchomotor tone, but increases as large as a third have been reported. Anti-sialagogues also affect sweat glands because the sweat glands are innervated by the central nervous system and use cholinergic transmission. This may lead to an increase in body temperature, and the effect may be substantial at large doses of the anticholinergic agents. In terms of heart rate, as we mentioned, atropine has the greatest effect, much greater than glycopyrrolate or scopolamine. And the route of administration affects how much the heart rate increases, with intravenous administration of atropine causes a much greater increase in heart rate than intramuscular. And some have suggested that actually heart rate decreases transiently after intramuscular administration of atropine because of a peripheral agonist effect of the anticholinergic agent. Anticholinergic agents, however, do not have an effect on the gastric fluid characteristics, pH or volume. They may relax the GE junction, and it is possible that aspiration risk increases, but there is very little data on this, and it would certainly not be a strong answer that I would be looking for. In terms of aspiration, however, there are some characteristic drugs that we do need to pay attention to. The H2 receptor antagonists block histamine-induced hydrogen ion secretion. They directly increase gastric fluid pH. So the H2 receptor antagonists increasing gastric fluid pH, however, have no effect on gastric fluid volume or emptying time. So they have a specific effect on one of the two characteristics of the gastric fluid. Their antagonism occurs in a selective and competitive manner with few side effects. So the H2 antagonists can be used to treat allergic reactions as well, or to prepare a patient for exposure to a trigger, such as a radiologic dye, by blocking their responses. So for example, 300 milligrams of cimetidine orally or IV 1 and 1.5 hours pre-op can raise the gastric fluid pH to greater than 2.5 in about 80% of patients. But cimetidine, you should be aware, does cross the placenta, although I don't think it's used much these days, and the adverse effects in the fetus remain unproven. The gastric fluid effects of cimetidine raising the gastric fluid pH may last as long as 3 or 4 hours. The problems with cimetidine is that they inhibit or compete with some hepatic isozymes, the ones we are particularly concerned about. 3A4, which is responsible for metabolizing about 50% of the drugs we use, and 2D6, which is responsible for about another 20% of the drugs. And therefore, it can prolong the half-life of a number of drugs, including diazepam, Inderal, and lidocaine. The clinical significance after 1 to 2 doses, though, of cimetidine is uncertain. It's really associated with chronic administration of cimetidine. Rarely have life-threatening dysrhythmias and arrest occurred after cimetidine administration, but these are likely to be the consequences occurring in patients who are critically ill. And it is important to realize that cimetidine does not change the pH of gastric juice that's already present in the stomach. It only prevents the secretion of more acidic gastric fluid. Ranitidine has all but replaced cimetidine because it is a more potent, specific, and longer-acting agent than cimetidine. It is given, when it's given, it's parenterally. It decreases gastric fluid pH within 1 hour of administration. It is effective in decreasing the number of patients who are at risk for aspiration, just as cimetidine does, and produces fewer cardiovascular or central nervous system side effects. Its effect on gastric fluid pH may last up to 9 hours, clearly superior to cimetidine, particularly when associated with long procedures where aspiration risk is a problem at the end of the surgery. Famotidine, which is not widely used, but I guess you need to be aware of it, is a third H2 receptor that has been used preoperatively to raise gastric fluid pH. Its pharmacokinetics are similar to those of cimetidine and ranitidine, but it has an even greater serum elimination half-life than the other two drugs. And nizatidine is another agent that does not seem to have any different characteristics than the preceding two. Omeprazole represents a different category of agents that reduce the gastric acid secretion by competitively binding with proton pumps in the parietal cells of the stomach. Its effect on gastric pH may last as long as 24 hours, but it too acts primarily to increase the pH of the gastric juice, not any reliable effect on gastric fluid volume. Antacids that we may give are used to directly neutralize the acid already present in the stomach, so it doesn't affect the secretion of gastric acid. It's only neutralizing the acid already in the stomach. And given 15 to 30 minutes before induction of anesthesia, it's almost 100% effective in raising the gastric fluid pH more than 2.5. Sodium citrate is the classic non-particulate antacid, and we use that in obstetrics patients very commonly. And they themselves do not cause pulmonary damage if they are aspirated. However, aspiration of gastric fluid that does contain particulate antacids may cause severe and persistent pulmonary damage, no matter what the gastric fluid pH is. These antacids do work immediately. There's no lag time. But as I said, there is a small increase in gastric fluid volume, unlike the H2 receptor blockers that do not have that effect. The effect on volume, though, is small enough that we would proceed in giving that volume despite the fact that the volume of the gastric juice may increase. Antacids may slow gastric emptying, and complete mixing of all gastric contents with the antacid may be questionable in the immobile patient, so it's better that they move around. And again, the effect of these antacids on food particles in the stomach is nil, and therefore aspiration will still be a problem if the food particles are aspirated. Metoclopramide is a completely distinct agent, which is a dopamine antagonist that stimulates upper gastric intestinal motility. It increases the gastroesophageal sphincter tone and relaxes the pylorus to empty the stomach. It has antiemetic properties. While affecting GI motility and gastric emptying time favorably, it has no effect on the acidity of the gastric fluid in the stomach, nor any effect on the gastric acid secretion. We administer it slowly over 3 to 5 minutes to prevent abdominal cramping, and it has an elimination half-life of 2 to 4 hours. But there are contraindications to this agent, and number one contraindication by far and away is that it should not be given to patients with bowel obstruction. There is no guarantee that having administered metoclopramide that the stomach is empty. Unless we do an ultrasound to check for the contents of the stomach, we do not know that it has been effective. There is some attenuation of the effects of metoclopramide by the prior or concomitant administration of anticholinergic agents or opioids. Again, the metoclopramide and drugs from its same category do not decrease gastric fluid volume or increase gastric fluid pH. It may have less of an effect after administration of sodium citrate, but it is often combined with an H2 receptor antagonist like ranitidine before elective surgery to enhance gastric motility. Our next question. A 39-year-old male. He presents for laparoscopic appendectomy, having last eaten a meal 4 hours before. Which of the following factors would be most likely to reduce lower esophageal sphincter pressure, predisposing the patient to regurgitation and aspiration? A history of vagal denervation of stomach and lower esophageal sphincter. B, succinylcholine. C, neostigmine. And C, cricoid pressure. And D, neostigmine. Which of the following factors would be most likely to reduce lower esophageal sphincter and predispose to regurgitation? The answer is cricoid pressure. Even though you may not think it should be, it is. Because the barrier pressure is the difference between the lower esophageal sphincter pressure and the gastric pressure. That determines the risk of gastroesophageal reflux. High intragastric pressure can overcome the lower esophageal sphincter and cause reflux. This is unlikely to occur in individuals because the lower esophageal sphincter exceeds the intragastric pressure. Low to normal barrier pressure is present in GE reflux, and there is no distinct cutoff. Vagal denervation does not affect the active functioning or resting tone of the lower esophageal sphincter, but reduced tone can occur in obesity, hiatal hernia, and pregnancy. Anesthetic agents, many of the IV agents, opioids, anticholinergics, and inhaled agents decrease the barrier pressure, whereas antiemetics, cholinergics, antacids, and succinylcholine increase the lower esophageal sphincter and therefore prevent regurgitation or increase the barrier pressure. Non-depolarizing agents and H2 blockers do not affect lower esophageal sphincter. But cricoid pressure in both the conscious and unconscious patient decreases lower esophageal sphincter and therefore the barrier pressure. Why? Because when the upper esophagus senses pressure and it can't tell if the pressure is external or internal to your esophagus, it thinks there's a food bolus coming down the esophagus and it has to relax the lower esophageal sphincter to let it through. So that is why the barrier pressure is actually diminished. The pressure that resists regurgitation when you apply cricoid pressure. So if cricoid pressure is not properly applied or not positioned properly, it's possible that you may have more regurgitation that passes by that cricoid pressure and leading to aspiration when it is applied. Succinylcholine increases lower esophageal sphincter primarily by its effect on the skeletal muscle in the diaphragm. So what is a critical pH in gastric aspirate beyond which aspiration pneumonitis will occur, and at what pH does damage occur, and what's the volume of the aspirate? Well, the critical pH has been and is 2.5. At a pH value greater than 2.5, the response is similar to that of distilled water. So we know we're in safe territory if we can get the pH above 2.5. Maximal pulmonary damage, that occurs at an aspirate of pH 1.5. And a patient is thought to be at risk when there is a greater than 50 ml volume in the stomach, which corresponds to 0.8 cc's per kilo, mils per kilo, and a pH value of gastric juice less than 2.5. What does the literature say about the use of steroids in the management of pulmonary aspiration? It's controversial. And as you can read, we know the benefits of steroids, but their effectiveness depends on the pH of the aspirates. When the pH of the aspirate is in the range of 1.5 to 2.5, steroids seem to have a beneficial effect. And you can see the administration of that. But when the pH was less than 1.5, the pulmonary parenchymal damage was maximal and steroid therapy was ineffective. So when the pH value is greater than 2.5, the response is similar to that of water, as we said, so there was no benefit of steroids. With pneumonia caused by gram-negative bacteria, it was more frequent after aspiration in those treated with steroids than in those who were not, which raises some concern about the use in the ICU. 2 multicenter trials demonstrated no benefit from high-dose steroids in ARDS, and thus corticosteroids generally cannot be recommended. Now, let's talk about beta blockade, because on every time out these days we're asked whether or not beta blockade should be administered. So for patients with known or suspected coronary artery disease, preoperative beta blockade may add to the safety in the perioperative period. They have reduced mortality and the incidence of non-fatal MIs after surgery. The current recommendations state that beta blockers should be continued throughout the perioperative period in those who are already on or taking beta blockers to treat whatever it is, arrhythmias, angina, or hypertension. Perioperative beta blockers should only be initiated for those patients undergoing vascular surgery at high cardiac risk due to signs of ischemia on preoperative testing. Otherwise, in ambulatory surgery, there is no evidence that beta blockade should be started on those who are not on it. And worse is that if you do start it, there is an increased risk of untoward complications. What about statins? And statins can reduce cardiovascular morbidity and mortality by a lipid-lowering effect. Enhance nitric oxide-mediated pathways, reduce inflammation, and have cardioprotective effect. There is a very small risk of rhabdomyolysis with statin therapy, and basically we should titrate this statin therapy to maintain your appropriate lipid-lowering level. But the current recommendations are to continue statin therapy throughout the perioperative period in those who are already taking the medication, but there is no evidence to initiate it in those who are not already taking it, and there's some evidence that this class of drugs may have a benefit in those undergoing vascular surgery and those with one clinical risk for myocardial ischemia about to undergo intermediate risk surgical procedures. Our next topic is perioperative infection control. And the National Surgical Infection Project recommends that all of the following antibiotics should be administered within 1 hour of surgical incision, except one. A, cefazolin, B, vancomycin, C, clindamycin, and D, gentamicin. The answer, vancomycin. So the National Surgical Infection Project recommends that antibiotics be administered within 1 hour of incision, or at least 50% of it before skin incision, except for two groups. One is antibiotics that are vancomycin or any of the fluoxetins like Cipro, because these can be given up to 2 hours before incision. And the second group is when a tourniquet is used, the antibiotic should be administered just prior to the inflation of the tourniquet in order to reach the source of the surgical site. Patients already receiving antibiotics may have customized timing, and there are dose increases that have been recommended in the American Journal of Infectious Disease a couple of years ago. For example, the standard dose for cefazolin is now 2 grams IV, and you should make sure that your data is up to date on that.